According to up-to-date and standard diagnostic criteria, a positive urine culture is traditionally defined as the presence of greater than 10 to the fifth colony-forming units, CFU, per milliliter of a uropathogen, accompanied by pyuria. Pyuria is typically indicated by an elevated leukocyte count or a positive leukocyte esterase test on urine dipstick analysis. In cases where the colony count is below the 10 to the 5th CFU/ml threshold, a urinary tract infection, UTI, may still be diagnosed if the patient presents with supportive clinical symptoms and concurrent evidence of pyuria. Thus, the interpretation of urine culture results requires correlation with both clinical presentation and urinalysis findings to avoid underdiagnosing infection in symptomatic patients with low-grade bacteriuria. This result shows two organisms with colony counts below the traditional threshold of 10 to the power of 5 CFU/ml. The presence of E. coli 10 cubed and Enterococcus faecalis 10 to the power of 4 does not automatically rule out an infection. If the patient has symptoms, dysuria, frequency, urgency, and signs of pyuria, positive leukocyte esterase on dipstick, or elevated white blood cells on microscopy, this culture result would be considered consistent with a urinary tract infection that if the patient is asymptomatic and has no pyuria, this result more likely represents contamination or asymptomatic bacteriuria, which often does not require treatment. When a urine culture reveals the presence of two distinct uropathogens, the selection of appropriate antimicrobial therapy becomes more complex. When facing multiple organisms, finding a medication and antibiotic that is going to be effective for both organisms is the goal. In this scenario, Organism 1, Escherichia coli. Organism 2, Enterococcus faecalis. The sensitivity profile may show that while Enterococcus is sensitive to ampicillin, the E. coli isolate is resistant. Therefore, ampicillin would not be a suitable choice for empiric or directed therapy, as it would fail to eradicate the resistant E. coli. The clinician must review the full antibiogram to find an agent to which both organisms demonstrate susceptibility. In the example provided, nitrofurantoin and levofloxacin may represent an appropriate therapeutic option, provided that both the E. coli and the Enterococcus isolates are confirmed as sensitive to this agent. This principle ensures that the prescribed monotherapy is capable of covering the entire spectrum of identified pathogens. Treatment considerations for UTI. When a urine culture and sensitivity report is available, the choice of antibiotic is not just about picking a drug to which the bacteria is sensitive. It requires a balanced evaluation of several key factors. 1. Efficacy, based on sensitivity table, is the foundation. The sensitivity report is the starting point. It tells you which antibiotics are likely to kill the organism. An agent to which the specific uropathogen, e.g., E. coli, is reported as S, will be selected. Choosing a drug to which the bacteria is resistant, R, will lead to treatment failure. Whenever possible, guidelines and antimicrobial stewardship principles recommend using the most narrow-spectrum antibiotic that is effective to minimize disruption to the patient's normal flora and reduce the risk of promoting further resistance. 2. Cost. The cost of a medication, which can vary significantly based on insurance formularies, pharmacy pricing, or if paying out of pocket, directly impacts a patient's ability to fill the prescription and complete the course. Patient adherence. First-line recommended antibiotics, like nitrofurantoin, TMP/SMX, are often available as low-cost generics, making them highly accessible. 3. Risk of adverse effects. Patient-specific factors must be considered for the individual patient. A documented allergy, e.g., to penicillins or sulfa, will rule out entire classes of drugs. Drug interactions. The patient's medication list will be reviewed for drug interactions. For example, TMP/SMX can interact with warfarin or certain blood pressure medications. Contraindications must be considered. Certain antibiotics are not safe for everyone. For example, nitrofurantoin should be avoided in patients with renal impairment. Consider the side effect profile. Some drugs cause more GI upset. while others, like fluoroquinolones, carry boxed warnings about tendinitis and nerve damage, making them second or third-line choices for uncomplicated cystitis. 4. Resistance rates. Sensitivity reports show the susceptibility of the specific bacteria from your patient. However, resistance rates refers to population-level data. Your hospital or local community tracks what percentage of, say, all E. coli are resistant to a drug like ciprofloxacin. Empiric versus directed therapy. If local resistance rates to an antibiotic exceed 20%, it is no longer considered a reliable option for empiric therapy. For directed therapy, a result of S overrides the local rate for that patient, but the rate should still inform your choice to avoid promoting further resistance. 5. Drug availability. You must ensure the selected antibiotic is on your institution's/hospital's formulary and is currently in stock at the pharmacy. For simple cystitis, oral therapy is the standard. However, for more complicated infections, IV therapy might be required, and an equivalent oral option should be ensured for step-down therapy when the patient is ready for discharge. Risk factors for Achilles tendon pathology, tendinopathy, and rupture. The risk of developing Achilles tendinopathy or experiencing a tendon rupture is multifactorial. 1. Patient demographics and physiology. Age greater than 60 years. The tendon naturally becomes less vascular and more degenerative with age, reducing its tensile strength and healing capacity. Male sex. It is clinically notable that ruptures are significantly more common in men. 2. Iatrogenic, medication-induced. Corticosteroid therapy, both systemic and local, injected, steroids can weaken tendon structure, increase the risk of degeneration and mask pain, leading to overuse and eventual rupture. Fluoroquinolone antibiotics. This is a critical drug interaction point. These antibiotics, e.g. ciprofloxacin, levofloxacin, have a direct toxic effect on tendon cells. Fluoroquinolone antibiotics, such as ciprofloxacin or levofloxacin, carry a black box warning regarding the increased risk of tendon rupture. 3. Comorbid medical conditions. Renal failure. CKD patients with chronic kidney disease, especially those on dialysis, have a higher prevalence of tendon disorders, likely due to metabolic imbalances and the accumulation of waste products that affect collagen health. Diabetes mellitus. Diabetes leads to the formation of advanced glycation end products, AGEs, in collagen, making tendons stiffer and more prone to injury and degeneration. 4. Musculoskeletal history and activity. History of musculoskeletal disorder. Any prior injury or structural issue in the lower extremity can alter gait and place repetitive abnormal stress on the Achilles tendon. Current tendinitis/tendinopathy. Active inflammation or degeneration is a direct precursor to rupture. If the tendon is already painful or damaged, the threshold for complete tear is significantly lower. High-impact activities. Weekend warrior activities. Sudden increases in activity, especially sports involving running and jumping, are common mechanical triggers. Fluoroquinolone antibiotics, such as ciprofloxacin or levofloxacin, carry a black box warning regarding the increased risk of tendon rupture. When reviewing a patient's chart or taking a history, if you see a combination of these factors, e.g., a 65-year-old diabetic patient on steroids, you should avoid fluoroquinolones for any infection if alternative options exist. Educate the patient. If a fluoroquinolone is absolutely necessary, e.g., pan-resistant infection, the patient must be warned to stop the drug and seek immediate care at the first sign of tendon pain, swelling, or inflammation. UTI treatment decision-making process. Start with the list of S antibiotics from the sensitivity table, efficacy. From that list, eliminate any drugs that are contraindicated for the patient or have unacceptable adverse effect risks. Prioritize the remaining options based on which are the narrowest spectrum, have the lowest cost, and are readily available. Consider the local resistance rates to ensure you are choosing a sustainable option that aligns with your institution's antimicrobial stewardship guidelines.